Welcome everyone to this webinar. This is put on by the Society for Medical Decision Making, and today we are going to be talking about the Advisory Committee on Immunization Practices. The title of this webinar is Understanding the ACIP, Evidence, Policy, and Practice in U.S. Vaccine Recommendations. Some light housekeeping before we get started. My name is Abram Wagner. I'm an assistant professor of epidemiology and global public health at the University of Michigan, and I will be the moderator for today's session. If you have any questions throughout the webinar, if you have technical questions, you can put them in the chat box. We also have a Q&A box that you're able to put any questions that you want to ask the panelists. This webinar has been generously hosted by SMDM, the Society for Medical Decision Making. This is an international transdisciplinary group of people who are interested in improving the health of individuals and populations. SMDM comprises researchers, clinicians, educators, managers, and policymakers who work in hospitals, universities, corporations, foundations, and government agencies throughout the world. SMDM can provide you with a scholarly home and opportunities for collaboration, professional growth, networking, and mentorship. And so we invite you to join our society. A few upcoming SMDM events. If you are already existing in this world and you want to learn some more technical skills in R, there is a microsimulation modeling course, which is led by Petros and Lean. And this will be teaching you how to use individual-based state transition models in decision making. And that will be on July 23rd. If that's a bit more advanced and you want a bit of a survey introduction to the field, SMDM does offer a core course certificate program. So in September and October, there are 4 introductory courses to medical decision making and cost effectiveness analysis, which are offered by the Society. And that is something that we provide for people who might be clinicians who are getting into this world, or it could be other people, other academics or people from the public who might just want a deeper understanding of some of the things that we are going to be talking about today. I'm very pleased to have 3 renowned panelists who are going to be part of this discussion today. Kevin Alt is a board-certified obstetrician gynecologist. He is a professor at Western Michigan University Stryker School of Medicine, where he was department chair of obstetrics and gynecology from 2022 to 2024. He is a graduate of Butler University and Indiana University School of Medicine and completed his residency at Ohio State. His clinical and research interests include women's health and infectious diseases. Hank Bernstein is professor of pediatrics at Zucker School of Medicine at Hofstra Northwell in New York. He has been a general pediatrician in private practice, served in the National Health Service Corps, and has been chief of general academic pediatrics at several urban, suburban, and rural children's hospitals. His private, community-based primary care experiences in combination with academic leadership responsibilities have provided him with a value-added translational science perspective. We also have Veronica McNally, who is a licensed attorney and the director of trial advocacy and externships at Michigan State University College of Law. In 2024, she was appointed to serve as an attorney advisor on the Advisory Committee on Childhood Vaccines for the Health Resource and Services Administration, or HRSA. As the president of Franny Strong Foundation, she advocates for vaccine preventable disease awareness and vaccination, and she founded the I Vaccinate campaign, a public-private partnership with the state of Michigan. In 2018, she earned the CDC Childhood Immunization Champion Award. So thank you for joining this panel today. I actually just wanted to first ask each of the panelists what your experiences have been with the ACIP. So Kevin, if you were to start, what have your experiences been with the ACIP?
I was thinking about this in anticipation of this question. I think I've been involved with ACIP for almost 20 years, originally about pregnancy and vaccines, right before the pertussis whooping cough booster became a recommendation, and more recently from 2018 to 2022 as a member of the ACIP, and I continue to work on some working groups.
Hank, what has your experience been?
I've similarly been part of the ACIP for a couple of decades. I first was part of the Committee on Infectious Diseases of the American Academy of Pediatrics, and I was the liaison to the ACIP around influenza and then the pandemic in 2009. I then was a voting member of the ACIP from 2017 to 2021. And since my term ended in 2021, I have been on three ACIP work groups, the COVID-19 work group, the influenza work group, and the immunization schedules work group.
Veronica, what have your experiences been?
I served as the consumer representative on ACIP from 2018 to 2023.
I want to put a disclaimer before we discuss a bit more. I'm sure people reading the news have understood that the ACIP has undergone significant changes in its membership and structure recently. Our presentation today includes descriptions of ACIP processes, deliberations, and norms as they existed prior to these recent developments, and we aim to provide insight into the committee's historical role and function, and we acknowledge that some aspects may be evolving in the current political and public health context. We have just a few slides that we wanted to give you about the background of the ACIP before we convene a panel discussion.
So I'm going to do this part, and you could tell by our introductions that Hank and Veronica and I all overlapped quite a bit on ACIP and different prospects. And so I'm going to let them interrupt freely or raise their hand, or probably mostly interrupt would be fine. So I love history of medicine types of things, and the ACIP has a long history. As you can see, it started in 1964. And when I usually show this slide, I point out that we talk about a lot of the same things now as we did in 1964. If you look in the middle column at the bottom, there's a little discussion of immunoglobulin and in measles, and there was just a discussion last week of influenza vaccine. And so things have certainly changed. There are a lot more vaccines. Smallpox on the right-hand side has been eliminated. So, but the kind of things we talk about as far as recommendations and how they get to the public are pretty much the same. And as you can see, it switched from the Surgeon General to the CDC between 1964 and 1972. The other thing that I noticed on this slide when I was looking at it beforehand is kind of towards the top of the middle column. It talks about the relationship with some other groups, including the American Academy of Pediatrics, AAP, and the Red Book, which is a document that goes back, I think, longer than 1964 from our Pediatrics Society in the United States. And so that's the idea behind this committee, if I can extrapolate a little bit into the past, was to get everybody congruent on the same page. Next slide, please.
As a former member of the Red Book, it's 80 years old. And
Yes, I saw some things from the 1930s posted in the past couple of weeks. So
I wasn't there at the
no,
beginning, but
yeah, me neither. So believe it or not. So the role of the ACIP is to provide advice and guidance to the CDC director. And we convene, or we're convened to prevent vaccine preventable diseases in the civilian population. There are separate organizations for the military. And as I said previously, we're talking about FDA licensed vaccines. Occasionally, we talk about some things that are special use, such as meningitis vaccines when there's an outbreak. We talk about anti-sera, monoclonal antibodies, and that type of thing. The thing that's changed in the past few years is that the Affordable Care Act, I believe, is 15 years old this year. And so the recommendations of the Advisory Committee on Immunization Practices determines eligibility for both the Affordable Care Act, which I think is 15 years old this year, and the vaccines for children's, I think, was 30 years old last year, but it's been around for a little while too. And again, I'll let Hank and Veronica correct me if I've got wrong dates, even though I said I was interested in the history of medicine.
it's been around for a long time. And the importance is that vaccines are readily available for the entire population of the United States, the civilian population as well as the military population. We do not want finances to be a barrier to being up to date on vaccination.
And so about half of children, am I right, Hank, get their vaccines through Vaccines for Children?
Correct. And the other half is through commercial enterprises, and that's important. So at least the entire population is covered.
Next slide, please. And here we are at our group photo. We used to, when we met in person, we used to take one of these at the beginning. So this must be 2019 because I see all three of us in there. Usually 15 voting members, give or take a few. There are public health people. There's a family physician in there. There's a PEDS ID specialist, more than one PEDS ID specialist. As you heard, Veronica was the consumer representative in the past. Members are screened for conflicts of interest. You can read about our conflicts of interest on the ACIP website, and you spend a lot of time talking to lawyers when you get started, and then you get to meet with the CDC's conflict of interest people on an annual basis after that. If you listen to the beginning of an ACIP meeting or before a vote, you will hear the ACIP members declare their conflicts of interest, and some will recuse themselves because they have a conflict of interest. So next
Our
slide, please.
consumer representative, I'll add, is a voting member and is on the same plane as everyone else. He or she has expertise that represents the public, which is incredibly important as we make decisions on how to use vaccines in the population.
And Veronica was an excellent consumer representative before her, Cindy Pellegrini, who some of you might know through the March of Dimes and a transdisciplinary group, was also an excellent. So going back 10 years, we've had excellent public members on the ACIP committee. So
Thank you.
I'm not going to spend too much time on this. I already mentioned smallpox has been eliminated, but a lot of these other diseases, as you can see, have gone down tremendously. Unfortunately, they're in the middle. We're having a little bit of an outburst of more than a little bit of an outburst of measles and pertussis right now. And so, but several of these diseases have been eliminated from the Western Hemisphere, and we can talk about current epidemiology if we have time during the Q&A. So next slide, please. So this is a complicated slide, and I was an investigator on some industry-sponsored trials 20 years ago. So I'll give you a little bit about the HPV story. So back at the beginning on the left side of this, there was a vaccine candidate identifying animal models for human papillomavirus, which is the causative agent of many cancers. And since I'm an OBGYN, cervical cancer is the big one. And then there were trials of early trials, phase 1 trials that involve a few dozen individuals, and then phase 2 trials which involve a few thousand individuals. And the phase 3 trials for both the GSK version and the Merck version of their HPV vaccines were both around 20,000, if I remember correctly. And so based on data generated from those trials, they get approved by the FDA, which I think is coming up on a slide. And so somewhere, and I wasn't involved with the HPV working group at the time because I would have had a conflict of interest since I was an investigator on the trials. Sometime in the 20 years ago, Merck and GSK and CDC were talking about the phase 3 trials. And so there's a working group that gets formed to discuss those. And that comes up with a plan as it gets closer to approval for phase 4 trials, which are after approval, post-licensures. You can see there in the upper right, pharmacovigilance, which frequently involves using some of the various systems CDC and the military and the FDA have available to them to look at safety signals and more on effectiveness. And probably the best example that I can think of for the HPV vaccine is we now have data that's effective for head and neck cancers, so which was another HPV type of cancer that's more common in men. So next slide.
Sorry to interrupt again, but I wanted to make sure that it we acknowledge that safety is a theme throughout, both during the development and licensure, and then after the licensure. And actually, the monitoring of safety in the United States is historic, and there are different mechanisms. The vaccine adverse event reporting system, the VSD, the Vaccine Safety Data Link, as well as CISA and VSafe. So it is historic and it continues well after vaccines are licensed. So it's not just for licensure, but throughout their use in the country year after year.
And again, since this is a multidisciplinary group, we should give a shout out to our colleagues at VSD, top flight epidemiologists doing these phase 4 trials. You heard a little bit about that if you listened to the meeting last year. VSD covers about 3% of the American population, has provided us wonderful vaccine safety data going back again 30 years. So next slide. So there's a little bit of overlap maybe between what the FDA does and what the CDC does and ACIP. So VRBPAC is the FDA's approval group, and I'll welcome input from my colleagues here. They review data mostly generated by the company. That's usually who's putting these vaccines through FDA approval. And there's usually an 8 or 10 hour hearing about the individual vaccine where all that data is gone through with a fine-tooth comb, and then at the end of that meeting, there's an up or down vote to approve it for FDA. They don't talk about implementation and some of the things that we're going to talk about for ACIP and CDC. So what happens though, and I'll use HPV again as a example, the science continues to evolve. And so sometimes clinical use gets to be a little different than what was done in the clinical trials. And the clinical trials for the HPV vaccines, as I said, are getting to be 20 years old. So there's more data that comes in, and the ACIP certainly and the CDC certainly look at those data. So next slide, please.
Yeah. I'm actually a voting member of VRBPAC, and we explore all of the science around the vaccines and provide advice to the FDA and their decisions about licensure of the vaccine. And as you said, Kevin, the vaccines, then clinical considerations and how the vaccines are implemented within the United States is made by the CDC with the advice of the ACIP.
And you might see some crosstalk because I was a special, I forget what the terminology is. I should ask you since you're on VRBPAC, but as a special appointee for one topic for the maternal RSV vaccine. But the people who talked about respiratory syncytial virus were the expert epidemiologists from the CDC. So if you listen to both meetings, you would have heard both. So, and that's a nice segue to this slide because you see in the middle on the left side, subject matter experts, SMEs, you'll frequently hear them abbreviated, are people that are usually embedded within the CDC that are people that are experts in hepatitis, RSV, or influenza, and that type of thing. So I'm not going to delve too much into the membership of working groups, but I should say that they are diverse, and all that alphabet soup over there. There's pharmacists and internists and family physicians and nurses and a bunch of other groups and international representation as well. You can see the National Medical Association there, which is a group of Black physicians. So there's an effort to make a diverse group of people to be the members of a working group. And the working group kind of does the grunt work of churning through the data and trying to distill it down into what's usually referred to as evidence to recommendations. So, and I think that's the next slide if we want to go to that slide. Yeah, so So we have the science from the FDA, we have the approval, and we go through a lot of that background. But we also talk about, is this an acceptable intervention to the public? Are there certain risk groups that we should only be using the vaccine, or is it more broadly applicable? Are the stakeholders involved? Is it economically beneficial? How do we avoid making health disparities worse? We talked about that a lot when the three of us talked about COVID vaccines before we ever had a COVID vaccine in 2020. But I'm going to pause. I'm going to let you guys pipe in here because I feel like I'm not really doing this justice, perhaps.
I'm happy to chime in, or Veronica, I didn't, if you wanted to chime in, I'm happy to start. Um,
Yeah, please go ahead.
sure. So, I think it's important for people to understand where the science part uh, allows, it's fully based on science as far as recommendations for licensure or emergency use authorization, as happened with the COVID vaccine. But the ACIP really does consider more than just the science, and they use a framework called evidence to recommendations, as Kevin mentioned, and that is not just the science, but it really explores the problem itself, and it weighs the benefits and the harms, the acceptability by the public in order to uh, receive the vaccine. We also, as part of evidence to recommendations, look at resource use and look at the qualities, the quality adjusted life years, and the cost effectiveness of the vaccines. Equity is really very important. We need the vaccines to be fully available for the entire US population. And we mentioned earlier about funding through commercial insurers as well as through vaccines for children. And there also were a program, vaccines for adults, during the recent pandemic. And we also look at feasibility. How easy or challenging will it be to not only recommend these vaccines, but remember, one of my mentors likes to say that vaccines don't save lives, vaccination does. So it's how many vaccines get into arms that makes all the difference in the world. And I'll pause there.
Can we go to the next slide and see if Veronica has anything to say? Because we kind of bled into that slide a little bit. So,
Oh, sorry.
no, that's okay. I think that's hard not to avoid doing that. So,
The only thing I would add is that we consider the equity. And oftentimes the recommendations that we make are uh, they're important recommendations that we made since we're no longer on ACIP. But if we thought that a recommendation would be inequitable in some way, we had a really robust discussion around that. And I just wanted to mention that too.
and then I think the next slide, which is the final background slide, is all of us at a meeting. So I can see Hank in profile there. So I think Veronica and I are sitting next to each other in the bottom right-hand corner. But then on the outside are the liaisons, which are the different organizations, the American College of Midwives. I'm starting over the left-hand side here, the American Collegiate Health Association, the American College of OBGYN. And they're alphabetical is the reason I started on the left side of the liaisons. And then the public is there. I don't know. I haven't been to a ACIP meeting in person since the end of the pandemic. So I don't know if it's the room is as full as this meeting, but usually there's a few hundred people there. So and so that I think is the end of our presentation. So
Yeah, so we're going to switch to the panel discussion. For people who are attending the session, please use the Q&A box to ask your questions. I'm going to pull some questions from those. Otherwise, I have my own ones to ask the panelists. To start off, I would like to ask each of you, what kinds of epidemiologic and economic data did you find most persuasive during the ACIP deliberations? And Veronica, could we start with you?
Yeah. Vaccine effectiveness was really important to me, and burden of disease. So those are two things that I looked at. Obviously, the cost analysis was significant, but we have to protect people. Those are the things I would say stood out to me the most.
And Kevin?
I
I
agree with what Veronica, sorry, Kevin.
no,
I
that's
agree
like
with
go ahead.
I agree with what Veronica talked about. I think that it's also everyone always cares about safety, and the idea of the cost is really vaccine specific. It is very important for us to prevent morbidity, not just mortality. So that is those are factors that I also looked at. Many of the vaccines cause lots of illness in pediatric age population, for example, and it does prevent death, but more importantly, it also prevents illness, which in turn can be spread to adults and others. And so we want to be sure that we're able to do cradle to whatever age, 100 plus.
I think just to emphasize what you said, things like influenza and respiratory syncytial virus, are pretty appealing because that huge burden of disease for children, especially for RSV, but for flu for everybody. I think some of the vaccines that the economic data gets a little trickier on are things like meningococcal meningitis vaccines because it's a relatively rare disease, but it's frequently fatal or disabling, and it tends to be in outbreaks frequently. And so, probably just thinking back, everybody can think of a person at a local college or high school that died very unexpectedly of meningococcal disease. And so, some of those rarer diseases that I'm saying we because all three of us were on the ACIP at the same time. Have more back and forth about the economic data.
And that was factored in actually when with the discussions on ACIP with meningococcal B vaccine. And it was actually not a universal recommendation, but one that was a shared clinical decision making. Abram, you'll like that the shared clinical decision making, so it's really one that is based on the information and informed by the decision process between the patient, family, and the providers. And that still is the case for that at the moment.
So a couple of you had mentioned the importance of vaccine effectiveness studies, and we've gotten some questions about that in the chat. And I know there has been some talk about the need for like a placebo as a control group. I don't think we necessarily need to go all in that direction, but I would be curious, um, how were studies about vaccine effectiveness presented to you, and what kinds of information about like the methods and the study design would you get in, say, like a working group versus in like the full ACIP session?
Who wants to handle that one?
I can
What?
go on. I'll let you start,
Okay.
Kevin.
Well, frequently we will get previews of publications that are coming out in the New England Journal of Medicine or final results that aren't quite published from the industry sponsors of those trials and in the working groups. And then those get synthesized into presentations for the wider ACIP. Something like meningococcal B vaccines, since it just came up, was a saline controlled trial because there wasn't a comparator available for that vaccine. There are no other meningococcal B vaccines available at the time they were doing that trial. However, I don't know this data as well as Hank does, I suspect. But now, if you're doing a meningococcal B vaccine trial or combination vaccine trial, you'd have to include a comparator that has an active ingredient because you can't leave children and adolescents and young adults vulnerable in the control group by giving them a placebo. So it evolves. You compare new versions versus old versions the vaccine. Pneumococcal is another good example of that. We keep adding more types to the pneumococcal vaccine, the meningococcal vaccine, the HPV vaccine, all the different vaccines. So
Yeah, and it's very the when the studies are done, part of the phase one, two, and three that we talked about, we're looking at both safety and also efficacy. And efficacy is how well the vaccine works in the controlled situation of a study. But once it receives licensure or emergency use authorization, like the COVID vaccines, the effectiveness is added to the mix to be sure that the vaccines are doing what we say they're going to do. We don't necessarily continue to use 30,000 people in randomized controlled trial, placebo controlled. You don't want people at risk. So oftentimes we'll compare immunogenicity of a new vaccine to a previous vaccine, understanding what a correlate of protection is, and try to reach that in making recommendations for use of new vaccine products.
Hey, Ram,
I
I
think
just wanted to mention too that these meetings, the ACIP meetings, are public meetings. We have the opportunity to ask any questions that we have regarding the data that is shown. So it really is an incredible opportunity for the public to learn more about the vaccine recommendation process. And I would say there has been the great benefit of the recent media coverage is the fact that the public is starting to see what ACIP is designed to do.
Yeah, that's a great segue to another question I had, and some people in the chat wrote this. So many of the SMDM members, they do very complicated simulation models. Um, how well do you think people in the ACIP, how well can they understand some different simulation modeling? And maybe a second part to my question is, what are some ways that researchers can make their research more, I don't want to say palatable, but more understandable to an audience which might not have like the methodological expertise that went into doing this study, but what are some things that can help members of the ACIP digest the study findings a bit better? And maybe I'll start with you, Veronica, as the consumer representative on the panel.
Making sure that you have clear slides and to the graphing that kind of information is really helpful. I do want to highlight the fact that I found the summary slides to be very beneficial, that sort of gave us the big picture overview of what had been presented, because it reminds you maybe of some of it hours and hours into meeting. It reminds you of what some of the really important things that we want to be thinking about are as we go into these votes. So there really is, it's challenging to present heavy data and it's challenging to do the modeling. But I do think that the opportunity to ask questions is really a beneficial one.
I'll add that the modeling is incredibly important. And yes, sometimes it's challenging to understand it, but I think it's important for us to emphasize that a lot of the work is done in the work groups prior to presentation to the voting members of the ACIP. So a lot of the questions or confusion that might happen is um, the modeling is presented to the work group and questions come up to be sure that the interdisciplinary work group totally understands and creates slides that, when presented to the ACIP members and the public, as Veronica said, are crystal clear and understandable to everyone. And yes, a lot of them are peer-reviewed publications that are incorporated, but the slides, all kinds of questions that people have thought of, have been parsed out through the work group deliberations that happen on an ongoing basis in between the three meetings of the ACIP throughout the year.
So a couple of you had previously mentioned how equity is really important, and that's coming through in some of the questions. And I wonder if you could talk a bit more about the importance of equity. And I could think of a number of different scenarios. Like, is there a trade-off where you might prioritize equity more than some other factors? Or and how do you have those kinds of discussions about equity, and when have those popped up?
Do you want me to go,
Oh,
Hank?
go ahead.
Well,
Sure,
I mean, there's
you
some
can
great
start.
examples right now, and since Dr. Bernstein, since Hank's a pediatrician, maybe I'll start with respiratory syncytial virus. If you look at, you know, children who get RSV or people my age and older who get RSV, being in a socially vulnerable community puts you at higher risk. And so one of the things that we discuss in the evidence to recommendations guidance is, are we going to make that worse? You know, are only the people that are going to get the vaccines are the people with insurance, good insurance, the people who have access to things. So are you going to make health inequities worse? And we usually vote on that in the working groups. And so, you know, given this evidence that we're giving you today, and then you talk about it later. You come back with implementation issues later. So, and I can think of a bunch of others, human papillomavirus and COVID, and all of them have that kind of aspect to them that they have the potential to make disparities worse. So,
And then just to piggyback off of that, the type of recommendation that we would make, if it's going to be shared clinical decision making, is that going to be more equitable or less equitable? So those are the types of and a couple of examples of types of issues that we confronted.
In equity, I'll add that on top of both what Kevin and Veronica said, equity is one of the elements, and it gets the same weight as all of the other elements in that evidence to recommendations framework that we talked about earlier. So it is really important that when you think about those pillars again of ACIP, it's not just the science, but implementation as well and equity. We need to make sure that these vaccines can reach each and every population. And so the epidemiology of different diseases varies among the population, and we need for that vaccine to be readily available for the entire population, especially those at highest risk.
Another question which is coming through is the types of recommendations that you might issue. And so there's sort of like a universal recommendation, you know, a broad-based recommendation for everybody, you know, maybe within a certain age range that to get a vaccine, or there could be more of a shared clinical decision making. You know, maybe this is a vaccine where someone should talk to their healthcare provider before getting it. And I think more recently we have had some discussion about that with things. I think Manage B might have been part of this, RSV, Mpox certainly. So I'm wondering how you have handled in the ACIP discussions about like what kinds of recommendations to make, particularly as a universal one might seem to be a bit simpler. But maybe there is blowback among certain groups about like needing to get a certain vaccine. And of course, there is the perspective among some that we just have too many vaccines. So there is sort of like a countervailant kind of opinion coming along in the population. So again, maybe I'll start with Veronica again. Like, was there, how did you view this, like the shades of different recommendations you can make, and how did you come to a decision?
These are really nuanced. There's a lot of time spent again in the work group trying to arrive to the best possible path forward with a lot of input from people who have great expertise. So once it gets to the ACIP, the work group input is provided, and there's a majority view that is shared. And then, of course, there are opportunities to understand if there were minority viewpoints that existed during the work group discussions. And that process is really insightful, and I don't know that there's a better way to do this.
I agree with Veronica in that it's really important for us to think about how we're going to make these recommendations, and the discussions really do happen with the work group making those decisions. For me personally, I think every vaccine is a shared clinical decision making. No one administers a vaccine without getting permission from an individual. And so we're required to use vaccine information statements, which have all the information about the vaccines, but no vaccine is given without the permission of the patient and or the family if we're talking about young pediatric patients. So it is shared clinical decision making, and the epidemiology drives whether or not, in my mind, whether or not it should be universal versus specific to a subpopulation.
I will just add that as the consumer representative, I had some concern about a recommendation for shared clinical decision making because I always felt like it placed a burden on the consumer to possibly know more and to be able to have those conversations with their provider or the person who's going to vaccinate them. And there were things that they maybe didn't know or a baseline knowledge that didn't exist. So when we got to that point in time, I wanted to make sure that we had very significant discussions about a shared clinical decision-making recommendation. And I would note, we saw all different types of vaccines for diseases that we vaccinate everyone against, and then things that just happen for people who are traveling to certain parts of the world. So every single discussion for every single vaccine was very different.
I wanted to follow up with something that you had mentioned, which is a minority opinion. Could you talk a bit about how decisions were made? Was it typically more consensus driven? Were there contentious votes where there was a substantial minority opinion, and how kind of was that documented? I'd be interested in learning a bit more about that. Maybe this time I'll have Kevin start if you're able to talk on that.
Well, I was the chair of the hepatitis B working group, when we redid the adult hepatitis B recommendations, and we had about a 50-50 split. We had people that wanted universal recommendations, which I was in that group, for all adults to get the hepatitis B vaccine. And then we had a group that said, let's keep it to the younger adults who may not have been vaccinated as newborns and children. And that was the recommendation we eventually went with, only up to age 60, because that was the group that had the most incidence of new disease, the most incident cases. So, but you heard our debate in the working group as part of the presentation, and then you heard the people at ACIP kind of going at it a little bit. That was back during the pandemic, and I remember one of my children saying, "What are you guys arguing about for all the time on the because they were stuck at home? I was doing these meetings from home. What are you guys arguing about all the time on those meetings you go to, Dad?" So the, I guess it's by consensus, but it's not always 100% consensus, and there are reasonable people that have different opinions based on incomplete data or expense or some other things that we talked about in evidence to recommendations.
Yeah, there isn't unanimity, that is for sure. And there's a lot of discussions that go on in the work group. And as Veronica said, all of those opinions that have been discussed in the work group are then presented to the ACIP members, and they're the ones that then, as Kevin said, can go at it as well. And so the majority opinion, the minority opinion could be different based on what's been presented by the work group to the ACIP. but the voting members of the ACIP are the ones that make that decision. But it is not always unanimity around the table. In that picture that Kevin showed, there really is not always unanimity.
At the end of the vote, so after the vote happens, the voting members have an opportunity to comment on the vote. And there you will find that people may express why they voted one way or another. If they happen to agree with the minority opinion or majority view, that's oftentimes expressed at that time.
Um, a question someone had about the consumer representative specifically. Veronica, I was wondering if you could talk a bit more about how you view that. Did you view yourself as trying to represent different consumer interests? And there could be some consumers who have strong feelings either way about vaccines in general, about a specific vaccine, or did you view yourself as just having complementary expertise relative to other people on the panel? Yeah, so how did you kind of think through like the different types of pressures and who you were representing when you were on the panel?
Yeah, I mean, I represented the public. So all of those different perspectives I tried to consider in arriving to my decisions. I will say that I tried to ask questions that I thought that people would have. And I also tried to get input from the liaison representative. So if a vaccine impacted the elderly, for example, I would ask for the Geriatric Society to weigh in. If it impacted children, the American Academy of Pediatrics. So I really wanted to make sure that those representatives had a chance to weigh in if they had not yet done so, so that the public had information that may be helpful to them. These were Every perspective is an important perspective to be considered. And I wanted to mention that there was so much value in the public commenters because sometimes the public commenters raised an issue that we maybe hadn't considered or it wasn't as highlighted for us as they had made it during the course of their conversations or their comments. So the consumer representative is a really important position. It is one that was started by a it was started because there was a parent who had a vaccine injured child and they brought him in and he represented that consumer perspective and that position has continued for decades and I hope that it will continue in the future.
I'll echo what Veronica just said. So it's not only the important role that she played as a voting member of ACIP as the public representative, but every meeting there are a public comment and discussions about any of the vaccines, especially the vaccines that are being voted on by ACIP. And so the public is allowed to ask questions or raise their points. And as a former ACIP member, I found that very helpful because they would come up with issues that I may not have thought about or may not have been discussed around the table by the work groups or the ACIP members. So having a representative voting member on ACIP is valuable, as is the public comment section of every ACIP meeting.
So a couple questions came in about maybe the specifics of the US versus other countries. So one, the United States typically uses private insurance for many things, although we had detailed in some of the preliminary information that many children get vaccinated through the Vaccines for Children program, which is a federally funded program. But I was wondering, I guess two-part, like what is the role of the ACIP in our current system where we don't have a national health insurance program, which is widely available for everyone? So how is the ACIP important in that respect? And then I guess a second part would be, do you think there's a space for the US to learn or the ACIP to learn from other countries on how to do vaccine decision making? Had it ever been part of your role to kind of see what was going on with vaccine recommendations in other countries for their sort of their ACIP equivalents. And just to toss it out to somebody, Hank, do you want to start with this one?
Sure. So, I mean, it is important that the the recommendations of ACIP are important for the United States, but other countries look at what does the ACIP and the CDC recommend. But I will add that many of the studies that we look at in making decisions for the federal, state, and local recommendations do include peer-reviewed studies that have been conducted abroad in other countries. And we find that to be incredibly helpful. Most recently, one of the discussions around the use of COVID-19 vaccination in children, for example, the recommendations in other countries are different than the recommendations in the United States. And that does fuel some of the discussion as we come up with recommendations by the work group and the ACIP.
Okay, so in our last few minutes, I have a couple of additional questions to ask, but there are questions which are coming through from the audience about kind of the recent shakeup of the ACIP. I wanted to give each of our panelists like a chance to kind of issue some thoughts on what the future of the ACIP is and how you see it being important, not only in the past from when you were in it, but like what is the future like for the ACIP? And yeah, so with that broad question, Veronica, do you have a specific? I would like to hear from each of the panelists, but Veronica, do you want to start?
I think it's going to continue to be important for the ACIP to make recommendations that are unbiased, that are based in evidence, that are not swayed by any sort of ideology or perception. And I have faith that the CDC is going to be able to continue to make recommendations following GRADE and the evidence to recommendations framework. And I think that because of the spotlight that is on the organization right now, I do think there's a benefit to greater public awareness and greater involvement in various organizations across the country who are all talking about vaccination.
Hank?
Science rules. I do think that we need to keep in mind the importance of science in making decisions. And as one of the earlier slides that Kevin presented, remember that there's a lot that goes into it's very complex in making recommendations, but that after licensure and implementation of the vaccines, the safety and effectiveness of the vaccine is an ongoing, continuous process. And that's something that the ACIP needs to continue to look at. But when I mention that science rules, we have decades of information about some of the use of the vaccines, the effectiveness of the vaccines, the safety of the vaccines. I don't think we need to necessarily reinvent the wheel and go back to square one in looking at some of the vaccines. If the science dictates and shares the idea that the vaccine is safe and effective and does not cause certain conditions, then I think we need to move forward and make sure that we're promoting vaccination as best as we can.
And Kevin?
Well, I think what I would have to say is pretty similar to what Hank just said, maybe with a little caveat. The National Foundation for Infectious Diseases is a group that I belong to. I'm the vice president of the group right now. And I went to look at the ACIP charter to make sure that NFID was one of the groups for liaisons. And so I read through the charter. I don't ever remember if I read through the charter despite being involved with the group for 20 years. I mean, if you just obey the charter, we'd be in pretty good shape. If we just did the protocols, as outlined in the charter, things would go smoothly. Not that they can't be tweaked. The charter was revised in 2020, and it probably can be updated. But as Hank said, some of the information that was presented at the last ACIP meeting was discussed by ACIP in 2008. And really, there was no new information presented and no new safety concerns presented from what happened in 2008. And, it was the same sequence of events. There was a phase 3 trial, there was a VSD study, there was a discussion at ACIP. I mean, it went through all the things, several years ago. And so reinventing the wheel, I think, is a good phrase that I'll borrow from Hank. We've already discussed this.
So the ACIP is one of it's the major group, and it's so linked to policy making on vaccine recommendations here in the U.S. But for our audience members, sort of edification, what are some other groups, especially tied to different societies, that also issue vaccine recommendations? And I know we've had some conversations about this, Kevin, so I might throw it to you first.
Well, I already mentioned AAP, and they have staff to do a lot of the evidence-based things that other medical organizations don't. The American College of OB/GYN has a set of immunization guidelines for pregnancy. They go back to 2018 and are being revised. And I have been the primary author of that. And so that topic is covered by one of the organizations. I think it gets a little dicier when you talk about adults. It's going to be the issue. So,
The American Academy of Pediatrics certainly makes recommendations for the pediatric population, and they've done that for years, as was mentioned before. There is a committee on infectious diseases and the Red Book committee, and they do make recommendations. The American Academy of Pediatrics recommendations often harmonize with recommendations made by the ACIP. And the efforts are made in order to harmonize because we don't want to create confusion amongst the public. And so we really work very hard to harmonize recommendations with the various groups. Kevin is an obstetrician, so ACOG. We have the American Academy of Family Physicians. We have nurse practitioners, pharmacists, hospitalists. We have multiple liaison organizations that are really valuable in providing input as these recommendations are made and then implemented and then evaluated.
I'll just have maybe one final question for all of you. I know we're about at time, but thinking back to your time with the ACIP or with working groups associated with the ACIP, what was one difficult or very important decision that you had to make? Like what was one, thing that you really think back to when you think of your time at the ACIP? And Veronica, I'll start with you.
Well, I don't want to speak for all of us, but I might be speaking for all of us. And that would be in December of 2020, voting on the COVID vaccine and the prioritization, thinking through the prioritization. I think that was really challenging.
Hank?
Yeah, I agree with what Veronica said. I think people need to understand that when we do these studies, as was done with COVID vaccines, oftentimes the initial randomized control trial with COVID was in adults, and then there's age de-escalation and dose de-escalation. So just because the studies worked in adults doesn't mean that it applies to the younger pediatric population. And so there were multiple studies that needed to be conducted. And these decisions were very challenging. We know that there are many adults, for example, that are in long-term care facilities, and their need to be protected might differ from others. We know that healthcare personnel were another group that we needed to pay close attention to. Essential personnel, those people that were, working in our grocery stores and working all those essential services that life could not go on without them. We needed to be sure that the vaccine was available to them as well. So it wasn't just the age, but the population and the responsibilities that they had in serving the public that we needed to factor in. And it was not always black and white in my mind.
Kevin?
So, since we've already established I'm an OBGYN and established that healthcare workers were a priority, there's a fair amount of overlap between, young pregnant women in healthcare and the priority groups we were talking about. Healthcare workers skew young, skew female, and so we had to make a decision with limited data pretty early on whether we were going to recommend the vaccine during pregnancy, and we did. And by March or April of 2021, we knew that was probably a correct decision because of VSafe, one of the mechanisms we mentioned previously with vaccine safety. So, I think that's one of the real challenges for me is that, we're sometimes doing things based on an incomplete data set, and we have to extrapolate from there.
I'll add,
Well,
let me pick up to Kevin's comment though, because I'm a pediatrician. Vaccinating pregnant women for certain diseases makes all the difference in the world in protecting young infants who are very vulnerable for diseases like whooping cough, influenza, COVID. Those are RSV. So we do encourage pregnant women to be vaccinated. It not only protects themselves, but they pass their protective antibodies onto their newborns and young infants, and that really does make a huge difference. So making those decisions can be a challenge. I totally recognize, as Kevin said, but as a pediatrician, I look at it from both protecting mom, but protecting the baby and the family as well.
Well, I want to thank all of our panelists for coming today and sharing your expertise. This was really insightful for me. We had a great audience participation. Thank you to the audience for the questions that you listed. Again, I'm putting a plug in to SMDM. This is a wonderful society to join. We have a number of short courses coming up, and there is a discount on a membership, which will be provided to you via email if you signed up for this webinar. So thank you again to the panelists, and I hope you all have a wonderful day.